All right. My name is Kendall Choate. I'm a physical therapist and athletic trainer. And I've been working with the Oklahoma City Memorial Marathon for the past 6 years. This is going to be our medical team training video. And this is the first time I've really done this because in the past we've had training meetings where I've been face to face with a lot of you and training you about our protocols, what the marathon is all about, and then kind of what your role will be in the main medical tent this year. So let's get started. So the Memorial Marathon is in honor of the bombing that occurred at the Murrah Federal Building in downtown Oklahoma City almost 20 years ago, and this race is held in memory of those who died, and we had 168 Oklahomans who passed away in that tragedy. And this year is the 16th annual race. So last year we had over 23,000 competitors, and this year we should have over 26,000 as of today who've registered. The marathon also consists of several other races, such as the half marathon, which is usually where we see a lot of our problems with these athletes because they're usually 5Kers who think they can run an extra, 10 miles on top of a 5K. So, anyways, they come in with a lot of dehydration issues and undertraining and things like that. So, but we also have the marathon relay, which is actually the marathon, but it's broken up between 5 racers who run different lengths and legs of that marathon. We also have the kids marathon, which is actually just a 1.2 mile little course for the kids. It's a lot of these elementary school kids who've ran at least 25 miles, I guess, leading up to race day. So they've kind of accumulated that over the past school year. So they've run the final 1.2 miles at the marathon event. So, all right. So as far as parking goes, it's always a nightmare each year, and this year is no different. The best advice that I can give you is that you should really come early and see if you can find a spot that is as close to the finish line as possible. Your medical credentials are the key to you getting anywhere, really. But to really get close to that to the medical tent, you're going to need that credential because they have the streets blocked off upwards of a block or 2 blocks away from the actual finish line. So if you have that credential, you should be able to get anywhere. And I should have your credentials out to you hopefully by now, but if not, you should be getting it soon. There's one of 3 ways that you can get that credential, either by picking up directly from me at the clinic, or we can have it FedEx to your address, or you can pick it up the day of the race at the OUHSC Health Club parking lot. There should be a person in a cart stationed there to hand those out to you if you're on the list. The main medical tent is just north of the intersection of Northwest 6th Street and Broadway in downtown Oklahoma City. Another place, a place that I would suggest parking is that health club parking lot that I just mentioned a second ago. They have that kind of available for us to use, and we should have a guy there to shuttle you over from that parking lot to our tent. So you just might have to wait a few minutes for that to happen, but if not, you can always walk over or a few blocks to the west of that. All right, so keep in mind that health club parking lot is on the northeast corner of the intersection of Northeast 8th Street and Lincoln in Oklahoma City. All right, so as far as the main medical tent is concerned, it's like I mentioned, it's at the intersection of Northwest 6th Street and Broadway. It's 1 block south of where the finish line will be, so it's at Northwest 7th and Broadway. And then we're also going to divide this huge tent up into 4 quadrants, A, B, C, and D. And each one of you will be divided up into one of these quadrants. We'll also have a dunk tank in the very back that's going to be separated by a privacy curtain, and this is designated for racers who potentially are suffering from some kind of heat illness such as heat stroke or heat exhaustion, and they need to get their body temperatures cooled down. So all that you need to know is that when you show up, you'll be assigned to one of these quadrants. Okay. As far as the main medical staff is concerned, we have our medical director, Tom Caniglione. He's a physician, and he's been a part of the marathon since its inception. But then we have several others who are a part of our team, and all you really need to know, I guess, is just Tom's face, and then who he is, and then also who I am. And I'm in charge of the Blister Cramp Team, or the manual side, the wound care side of things. All right, so we're also broken up into two shifts. We have a morning shift and a kind of afternoon-ish shift. So if you have any questions about which one you're a part of, please contact me. Obviously, you signed up already on our sign-up sheet on the Google Doc, so no need to worry about that. As far as what our roles and responsibilities are as a part of this team, we're going to handle the blisters. We're going to handle the minor wound care things. We're going to drain those blisters and then bandage minor abrasions or lacerations that people might suffer while on the course. We'll be in charge of the manual therapy, such as therapeutic massage, stretching, myofascial release. And what I'm going to suggest here is just do what you're comfortable with and trained in doing so. A lot of you students don't have a lot of training with hands-on, so if you don't feel comfortable doing something, then let someone else kind of take over, and you just kind of observe and watch and just assist as needed. But we'll go over a few of those techniques before we finish here. And then some of our other last responsibilities include retrieving supplies, taking care of the documentation. Each runner will have a documentation sheet, so we need to make sure that their vitals are put in on there. And then we also need to be the ones who monitor oral ingestion of the post-race fluids and electrolytes. Everybody will get water or Gatorade, and they might even get an IV, so we just need to monitor those things and work alongside these nurses, just helping them out. We're not going to be the ones involved with the IVs, and that goes into the patient education kind of thing. So we're going to educate our patients on how to take care of themselves and manage their conditions to the best of our knowledge. And then also we need to be aware we are not involved with giving IVs, starting IVs, doing stitches, or giving out medication. That is not a part of our scope there in the medical tent. So also be willing to assist within your scope of practice, of course, the other healthcare providers there. If they need help, be flexible, okay? All right, so within these four quadrants within the tent, we'll be assisting and treating these incoming competitors, and they'll be split up within these four quadrants. Okay, so each quadrant will have a leader that I've designated, and here are the ones that I've selected this year. And each one of these teams will have at least one main blister drainer and one assistant. So usually the blister drainer will be the quad leader, but they might have you be the one who's in charge of that at some point after they've done a few and you've kind of seen how it's done. They might pass that on to you, and then you're the main blister drainer. And some of y'all will be the assistants, kind of being the helping hand. So here's some of the responsibilities of those two positions. The main blister drainer is to implement the appropriate blister care protocol. Drain the blisters as needed, apply Silvadene medication to blistered areas, wrap and cover the affected area, and educate the patient on post-treatment and care of the affected area. This is typically done by a physician, PT, or athletic trainer. But like I said, we might pass that off to one of you and monitor you closely as you kind of help out with that part of things. Like I said, most likely it starts out being the quad leader. The assistant just helps out the main blister drainer with any and all parts of the blister care protocol, retrieving supplies that might be required, discarding all supplies into the appropriate waste receptacles or into the sharps containers. So this is typically the student, like I've mentioned before. And as far as blisters are concerned, blisters are a small pocket of fluid within the upper layers of the skin, right under the epidermis. It's typically caused by forceful rubbing, otherwise known as friction, and the most common issues stem from either walking or running long distances, such as a marathon, wearing poorly tuned new pairs of shoes, which many new racers end up buying brand new shoes for these things, and they end up not spending enough time breaking them in, and so they end up getting blisters because of that. So most closed blisters are filled with this clear fluid called serum or plasma. We see many of our racers with blood-filled blisters as well. Keep in mind, if there is blood, So with any of these blisters that we treat, always wear gloves. If you're participating in any portion of wound care, it's always smart to keep yourself safe, keep them safe. All right. So as far as the blister protocol, and I'll show you a video of how I want this done and what supplies are incorporated into this process. But first thing is, when the racer arrives at the medical tent, have them lay down and prop their foot up on an available stretcher or table. Then the main blister drainer and the assistant will use universal precautions and put on gloves prior to treating all patients. A blister team member will then retrieve a pre-made blister pack, which will contain all of your supplies. It'll have everything from gauze to needles to bandages to Coban. But the main blister drainer will retrieve these packs and prep and clean the foot with an alcohol pad. When the area has been sanitized, one of the following will occur, depending on if the blister is either closed or open. So a closed blister is the one I kind of mentioned prior, is where that serum is filled within that blister, and the skin, that epidermis has not broken, so it's still filled with that fluid. Okay, so if this is the kind of blister you're dealing with, we want to begin by taking a sterile needle with a syringe appropriately attached and carefully insert the needle just under the first layer of skin at the most inferior edge of the blister. Using the syringe, slowly drain the blister of serum without any sudden jerks or shakes, because if you move the needle just right, you could poke that new layer of fresh skin, and that could really hurt them. So once all the fluid has been evacuated, click the safety and dispose of that first needle in the appropriate sharps container. You want to protect yourself and you want to protect the patient. You don't want to just be waving that around as you're kind of inspecting the site. Okay. Next, take a second sterile needle with a new syringe appropriately attached, and it should be filled with Silvadene. So you should have two separate syringes ready to go and two separate needles ready to go. So you want to carefully insert this Silvadene attached needle. Insert that just under the superficial layer of the skin at the most inferior edge of the blister, just like before. Slowly inject just enough Silvadene to fill that drained blister. And like I said, avoid those sudden jerks or shakes. Then once again, click that safety and dispose of that second needle into the appropriate sharps container. Protect yourself. No needle sticks. All right, so the second type of blister we kind of see is what we call an open blister, and that's where the skin has either been ripped away or it's been popped to some degree. So the skin might still be over it, but the fluid is drained out. Okay, so these are a little bit more pesky if it's been popped. So, but for these open blisters, you want to begin by taking a sterile needle with the syringe appropriately attached with the Silvadene. So you don't even need the first needle so you can pull fluid out, since that process already happened while they are running, or they've popped it themselves. But anyways, you want to once again stick that needle under the most superficial layer of the skin, if it still remains, at the lower edge of the blister. Then you want to slowly inject just enough Silvadene to fill that blister pocket without any sudden jerks or shakes. All right, don't want to hurt them. And then once you pull that needle out, click the safety and dispose of it in the sharps container. Okay, and as far as follow-up with the patient, you want to wipe and clean off the blister site with a new alcohol pad. You don't want to reuse the same one. Okay, and then you want to cover the blister with a Band-Aid, and then lightly wrap Coban around the foot and blister site to secure the dressing and provide protection. We don't want to restrict the blood flow of the foot, so make sure you keep it loose and light. Not too loose to where it falls off, but not too tight to where it suffocates their foot. All right, and then review and fill in any remaining patient documentation that might remain, and then also provide the patient with post-treatment education. All right, as far as that post-treatment education, here's what we tell them. You want to keep the treated area wrapped and covered for at least 24 hours. They are allowed to shower with the Coban on, and it shouldn't really mess anything up. Okay, and we also tell them if they're so hardcore about running, they should and could be able to run like normal without any negative consequences like pain in the next 30 hours or so after we apply that Silvadene. So the Silvadene is usually used for severe burns, but now they're saying it's great for blisters as well. The military uses the same technique, and that's kind of where we've taken it and adapted it from. But Silvadene also helps reduce pain and inflammation. And you might notice that the patient's able to walk out of there without any pain once we put that on there. So, but what this Silvadene does is it adheres that old top layer of skin down to the new, very tender, painful red layer of skin. So that's how it reduces the pain that they're dealing with. As far as needle safety, I can't express this enough, guys, but the goal is to have zero medical personnel with needle sticks. In the past, we've had issues with this, so that's why we're stressing it so much. But not all needle stick injuries are preventable, but the number can be reduced by using devices with built-in safety features, such as the needles that we will be using. There's different sizes of needles that we might use. You'll probably just see an 18 or 20 gauge needle. So, but they'll resheath with this little clicking mechanism, and then you want to still dispose that into the sharps container. So, so for closed blisters, you will need 2 separate needles. After you finish the first needle, click the safety mechanism and dispose of that needle in the sharps container. Then you can uncap and use the second needle after that. Make sure you click the safety. Don't recap needles. Okay. Click the safeties and dispose of them into the proper sharps container.
All right, so when we're going about the blister draining process, you need some supplies. So some of the supplies that we have here, come on over. We have our gloves, okay, that's the biggest thing, okay, gloves. We have our alcohol pads, bandage, co-band, 2 needles, 2 syringes. One of the syringes should have the Silvadene in it, ready to go, okay? So these needles are capped. These are both safety needles, okay? So after we use them, we dispose them into our sharps container, okay? So first things first, put our gloves on here. So go ahead and come right around on this side, okay? So as you can see here, as you come a little closer, okay, you can see we have our blister here, and I've kind of just got some bubble wrap to kind of simulate this blister. But I'm going to start out with our gloves, okay? So universal precautions for everyone, okay? No matter who you're dealing with or what patient problem is presented here, you want to use universal precautions to protect you and the patient, okay? So, okay, first step here, we want to clean the area, okay? Sanitize it. They've been running, they're sweaty. Potentially some bacteria around that area. You want to prevent any kind of infection later on, okay? So we use that alcohol swab. Then next we're going to use the needle and syringe that does not have the Silvadene, okay? We're going to remove the cap, okay? Got the needle here, and we're going to approach from the inferior side of the blister, okay? So also keep in mind, we want to go parallel with the skin. We don't want to go straight into the blister. We will potentially puncture that new dermis that is really fresh and tender and red. It's irritated, so we don't want to irritate it anymore. So we're going to try to go through that initial layer of the epidermis from the inferior side and go parallel to the skin so we avoid contact with that fresh layer, okay? So I'm going to come in, okay? Be real gentle here, okay? Once we enter that pocket, okay, we can drain the fluid out by pulling it out through the syringe, okay? Once we drain it, okay, we can pull that out. We want to make sure we cap the needle, okay? Once it's out, we're not going to use it again, okay? And take it, and then we dispose it into the sharps container, okay? Then with the syringe, we can dispose of that in the trash can, okay? Now from there, once we've drained the fluid off the blister here, uncap the other needle that should be connected to the syringe with the Silvadene, okay? We're going to try to do the same technique to avoid puncturing, that epidermis, okay? Going parallel, going to enter the bottom side and inferior side of the blister, and then we're going to slowly inject that Silvadene into the blister, okay? So we don't want to overfill it necessarily, okay? We want to put enough in there to where we can cover the entire surface of that epidermis, okay? And what you can do is insert a little bit and then slowly rub that around so you fill that up, okay? Once again, you're going to recap that needle. We want to prevent needle sticks, okay? So go ahead and toss that into the sharps container. But then also don't throw this syringe away that has the Silvadene. That stuff's pretty precious. We don't have a ton of it, and we can reuse this. Since we're injecting, we're not pulling anything out, so this stuff is still sterile. Okay, so once we've injected the Silvadene into the blister, we can once again take another alcohol swab. Okay, wipe the area down real good. Okay, and then from there, cover with a Band-Aid. Okay. Now all this supply should be in the blister pack or kit that is in each one of the quadrants. So you should have everything you need in that kit. All right. Okay, so we're going to cover that blister up real good there. Okay, and then we're going to finally cover with Coban. And you want to instruct your patient that, you know, to keep this Coban on for at least the next 24 hours, and they can shower with it on, so that should not mess anything up. But then also, if they want to run, they probably can get back out there within about 30 hours or so. Okay, so it's amazing stuff, the Silvadene, and I'll explain more in the PowerPoint. But so that's how we want to finish up here. And you want to go light. You don't want to go too tight with this. You can cut off circulation. You just want it to be nice and tight, and then they can put their socks and shoes right back on after that. Okay, so that's the protocol. Hopefully that makes sense. Watch this over a few times if you don't quite get it the first time, all right?
All right, so moving on to more of the manual therapy side of things. When dealing with muscle cramps, here's kind of what they are. And they're an involuntary and forcibly contracted muscle that does not relax, otherwise known as a spasm. If the spasm is forceful and sustained, it becomes a cramp, and cramps can be visible and palpable hardening of that muscle or muscles that are involved, and it's usually quite painful. They can last a few seconds to 15 minutes or occasionally even longer. It is not uncommon for a cramp to occur multiple times in the same muscle until it finally resolves. And keep in mind, guys, these runners will not be feeling very good. They're going to be dehydrated, possibly a little delirious. I mean, if they're hurting, they're going to be screaming and hollering. So don't freak out. Try to control the situation, get them calm, and begin stretching them. So some of the best treatments, like I said, is to stretch and massage these muscles. Muscle cramps in the extremities are common. Okay, so let's check these out. So some of the most common areas where we see cramps for runners are in the hamstrings, the quadriceps and hip flexors, sometimes the iliopsoas, the hip rotators such as the piriformis, the calf and peroneals, and then the tibialis anterior. So here's the muscle stretching protocol that we usually use here. So when a racer arrives at the medical tent, you want to have them lay down on the next available stretcher or table. You want to determine which muscle or muscle group is experiencing a spasm. You want to stretch the affected muscles for as long as required. This can get very tiring for you as the clinician, so here are a few of the techniques that you want to use. So for the hip flexor and quadriceps, you want to lay the patient on their unaffected side, facing away from you. And then you want to take one hand and grasp the ankle of the affected leg while the other hand takes hold of the knee of the same leg. You want to flex the knee and slowly extend the hip to pull the foot towards the back of the patient's head. This should put a good stretch along that quadriceps group and even the hip flexor. Next, you want to go, you can work on the hamstrings. Have the patient lay on their back while keeping the patient's affected knee straight and hips flat on the table. The clinician slowly pulls the leg up towards the patient's head. Okay, you want to hold that for as long as they can handle. Okay, as far as the calf stretch, is very similar to the last one you just did with the hamstring, except this time you're going to put the foot into a dorsiflex position, so you stretch that calf and that gastroc. So an alternate position is where they just lay supine with the hip and knee straight, and you just cup the bottom of the heel and then pull up on the toes towards the head, causing dorsiflexion. This will stretch more of the soleus. And then you can also stretch the peroneals a little bit by inverting the ankle, and that should put a little stretch along the lateral aspect of their foot and ankle. And then you have the tibialis anterior stretch. Patient should lie on their back with legs straight out. The clinician applies a downward stretch by plantar flexing the patient's ankle and pointing the toes away from their head. All right, and as far as follow-up is concerned with cramps, as the stretch is being applied, have the patient drink Gatorade and eat pretzels and or banana if available. This helps restore the fluid and electrolyte levels to normal. Ask a nurse or physician if the patient will need any further treatment, such as an IV. Many of them do, but it's always good to check. Review and fill in any remaining patient documentation, and from there you should be pretty good. And just monitor the patient, take care of them, carry them through this process, and if they need a ride afterwards, it's always good to find the person in charge of the golf carts to help them get a ride back to their vehicle or back to their hotel. So, all right, guys. Well, this is the training video. I hope you learned a lot. If you have any questions, feel free to contact me. Hopefully, you have my contact information already. So, we look forward to seeing you. We appreciate you helping out and volunteering your time. This is always a fun event.